as a dentist, it is very important for us to know what those whitish and reddish lesions are there in the mouth. Most commonly, your patients will be coming to you with ulcers in their mouth. And believe me, when I started dental school, and then when I finished dental school, when I was in my practice, when I'm in my practice, it can be really confusing when you have, when you see an ulcer. Sometimes you're really confused, like, is it what kind of an ulcer it is? Is it due to systemic disease? Because sometimes your patients are, not systemically healthy. And especially in those scenarios when the patients are not systemically healthy, even the smallest of the lesion, even an ulcer, tiny ulcer, could put you into doubt. So this video, I'm going to be talking about the most common ulcers that you see in the patients. And the most common ulcers that you see are apthous ulcers and herpetic ulcers. And it's very difficult, believe me, initially when you are starting out, or even if you've been practicing for a long time, sometimes it does become difficult to understand if that's an apthous ulcer or it's an herpetic ulcer. In this video, I'll discuss how to diagnose an apthous ulcer, how to treat, and the same thing goes for herpetic ulcers. If you do not know me, I'm Dr. Swati Gupta. I'm an international trained periodontist. I'm a practicing dentist in the US, and I teach for INBDE as well as prepare the students for SOP and resume preparation. The link to my email will be in the description at the end of the video. So I'm going to get started here. Let's talk about aphthous ulcers, also called as canker sores or aphthae. Most commonly, your aphthae or aphthous ulcers, they're going to present as shallow, round, painful ulcers. They're always going to be painful. The presentation is usually round and shallow, because if it's going to be dug out or deep, then definitely you know it's not an aphthous ulcer. It is probably related to some severe systemic disease or any autoimmune disease also. But your aphthae are round and they're shallow ulcers. Surface. Now, surface is really important. When I was just starting as a dentist, and even during dental school in the exam, it was very difficult to remember if aphthae are found in what surfaces. And it's a very common question you'll see even in your INBDE, or if you are preparing for any centralized exams like in India, any NEET or MDS exams. So non-keratinized surfaces. Non-keratinized surfaces means like your soft palate, your lip, cheek, floor of the mouth, and like in this picture, it is on the ventral surface of the tongue. How do you remember that aphthae is found on non-keratinized surfaces? Well, one way that I think many of you might be doing that to remember is that non-keratinized surfaces are most common surfaces. Like aphthae is basically why. I'll come to the reasons, but stress is one of the most common reasons for aphthae. And that being said, they'll happen anywhere on your cheek, on your lip, like a pimple. It happens anywhere. So aphthous ulcers can happen anywhere on any mobile mucosa like palate or cheek or floor of the mouth. Okay, I hope that helps you. I'm not sure. Who gets it most? Well, unfortunately, the most common population that gets it is in the females in their 20s or their 30s. Again, the way to remember is that, women try to be more perfect. They're always very perfectionist. Again, not saying about the opposite sex, but just a way to remember that stressed is one of the most common causes. Women in their 20s or their 30s, they most commonly get it, just like probably acne. And what is the size? Size is 2 to 3 to 10 millimeters. They can be small, they can be large. We'll talk about the major aphthous ulcers, but the size is usually very small. So here you have your presentation. If a patient comes to you, if you see a small, tiny, whitish erythematous lesion, like like here, a necrotic center, which has a very defined margin. If you can see here, it's a necrotic center, a very clearly defined erythematous halo or margin. That is usually the presentation of your aphthous ulcer, especially if it's a woman who's in a, I would say that at this point, after seeing so many patients, I do not just say that 20-30s age group. Let's just go by the thing that women, if it's a woman and if you have this kind of a presentation happening on any non-keratinized surface, it's shallow, it's painful, and the patient is talking about some factors, we'll be talking about those, then you can try to reach to a conclusion or a differential diagnosis that is an aphthous ulcer. Okay, and main thing is recurrent. There's always there. So in your history, please ask these questions also. Is it recurrent? How many times do you get it in a month? How many times do you get in a year? And then try to associate it with the etiology. Now, what is the etiology? Now, most commonly, it's been also associated with Streptococcus sanguis, or your, as in like your oral bacteria basically, or HSV or CMV, H. pylori infection. Well, H. pylori infection and others are limited literature available, but for definitely intraoral bacteria there is. Genetics, they say it runs in the family. Some studies, there are series of studies basically that say that some people are more prone to get ulcers as compared to others. Deficiencies, you must have noticed or heard that people say, oh, you've got an ulcer, yeah, start on vitamin B complex or start on vitamins, or you have iron deficiency, you have nutrition deficiency. Definitely nutrition deficiency can cause an imbalance in the intraoral flora, in the intraoral environment, and that makes you more prone for ulcers. Trauma, again, it's been suggested that trauma is also related to causing or predisposing you to an ulcer formation. Stress, like we've talked about, definitely stress is one of the very common reasons. And then allergies. I've not really seen many cases myself, but yes, when I was preparing this presentation, in the literature, there are articles that suggest that allergies can also cause ulcer formation or cause this cause of aphthae, and the most common is in your toothpaste. Sodium lauryl, the component that is in the very common in every toothpaste, is also one of the ingredients that can cause, or you can be allergic, basically you can be allergic to that component and get ulcers. So there are lots of reasons that can cause ulcers. And why do we need to know? Because if you've seen all my videos, I'm trying to rationalize everything. For everything, usually 99% of the time there will be a reason, and if you know the reason, then you know how to treat it. So same thing goes for ulcers. Definitely there is a short duration of time they would last, or you can enhance the healing by giving the patient a mouth rinses or anything. But if you know the reasons also that are predisposing that patient to get those ulcers, you can have a talk with your patient. If your patient is stressed out, if you've asked the history, what do you do? Maybe it's a profession that is making them very stressed out. Or if that's not the reason, if you see, probably ask them related to when. Is it related to you started something? Or maybe, how's your, when was your last physical? So what I'm trying to get at here is that the causes, the root cause has to be understood, and that will make you a proficient physician, and you'll be able to help your patient much better. Now, let's talk about recurrent aphthous major or severe form of aphthae. Now, these aphthous ulceration, like we see here, these are seen in very systemic diseases like Behçet syndromes, neutropenia, Magic syndrome, pharyngitis, HIV infection, and HIV patients usually present with recurrent aphthous major. So why it is important to know that what kind of an aphthae will you see in different situations? The reason is, like I said, that ulcers are the most common ulcers you see are the aphthous ulcers. But again, depending on the presentation, if they are tiny or if they are large, you can probably have an association with if the patient has an underlying systemic disease which is unknown to you or the patient has not declared yet, or if it's a tiny ulcer, the patient might be systemically healthy. Because it often happens if we do not know exactly what I'm looking at, and if I do not gather enough history, you might be just sending the patient back just to get a second opinion from someone. Whereas if we knew and if we could gather much more history, we could have sorted the issue right there and then and have a diagnosis. So in HIV patients, you will usually see these huge ulcers. So if a patient with a large ulcer comes, it's not only HIV but other systemic diseases too. You should ask more history if you haven't. Aphthous major, now they may exceed 1 centimeter in diameter, may persist for 6 weeks, and they leave a scar on healing. And again, history comes into play. You should ask the patient, have you been getting these ulcers before? And when they come, how long they stay. Usually an ulcer would not stay for more than 2 weeks, a tiny aphthous ulcer. But if it's a major ulcer, they stay for a longer duration, for at least 6 weeks. That means almost 1.5 months. And they leave a scar also upon healing. They can be found on other sites also. So this is your aphthous ulcer. Let's talk about treatment. Now, obviously, the first thing is you have to put your patient out of pain, right? They will say they're not able to eat, they're not able to swallow, depending on the location that there is. So you can obviously prescribe them over the counter, like Ora gel. Ora gel is over the counter. There are lidocaine preparations, topical anesthetics, which they can apply when they are eating, or they can apply when it at different times in the day. Just it gives some symptomatic relief from the pain. Also, what can be prescribed is tetracycline mouthwashes. There's a lot of literature that says tetracycline mouthwashes used for 4 times daily for 5 to 7 days also has a good effect. If you do not want to prescribe tetracycline mouthwashes, or your patient is not comfortable, then definitely chlorhexidine mouthwashes does the same twice daily, 5 to 7 days. It will provide some good symptomatic relief as well as it's antibacterial. So we'll make sure that the area stays clean and heals faster. If for whatever reason, also specifically like in aphthae, major aphthae, you can definitely think about corticosteroids or a dexamethasone solution, rinses with it. These are also help in healing. So everything that we're doing at this point is providing the patient some kind of comfort and hastens the healing. If not hastens the healing just by its direct action, but it makes sure that the site is clean so that everything heals up faster. Laser and chemical therapy are also proposed, but I'm pretty sure that in your practice, if you're seeing a minor aphthae, chlorhexidine mouthwashes are a good thing to go, and maybe an oral gel or topical anesthetic just to relieve the pain. And depending on the story, the history, what is the reason, maybe a kind of a counseling can also help. If you see nutritional deficiency or patient is stressed out, let's have a talk about including maybe multivitamins also in the regime. Okay, so that was about your aphthous ulcers. Now there's something called as recurrent herpetiform ulcers. What are these? If you see in this picture, you see a crop of multiple, look at this, shallow, they look like an octopus, shallow ulcers. And when you see multiple ulcers like these, sometimes people would confuse it with herpetic ulcers, because herpetic ulcers, as we'll talk about in the later part of the video, occur in crops. But what's the difference here again? These are occurring on non-keratinized mucosa. Okay, and they're usually present almost continuously for years with very relative short remission. So again, how will you diagnose the patient with recurrent herpetiform ulcer? How will you know if it is actually a herpetic ulcer, or if it's not, or if it's a form of the aphthous ulcer, which is a recurrent herpetiform ulcer? History. You have to ask the patient for how long these ulcers stay. Duration of the stay is really important because they are on the non-keratinized, so they're not herpetic ulcers. Again, I'll mention that. They do not respond to antibiotic or antivirals also. So again, another thing, like we were talking about in aphthous ulcer, you can use chlorhexidine mouthwashes. They will hasten the healing because they're antibacterial. These herpetiform ulcers do not respond to antivirals or antibiotics. Another difference, just to note that this difference is important to differentiate them from herpetic ulcers. Okay, so they're similar to aphthae because of their location on a non-keratinized mucosa. They're occurring in multiple locations at the same time. That kinds of make it similar to herpes, right? But like herpes, it does not, unlike herpes, it does not really respond to antivirals. Okay, so these are your herpetiform ulcers. Now let's talk about your herpes simplex. Herpes simplex again is very, very common. Herpetic ulcers or the herpes labialis, it's very common. And I have this funny story about a patient who came with um, herpes labialis on their mouth, and I'll show you the picture again. I think the best time will be to tell when I show you the picture. So let's just start with your herpes simplex. So herpes simplex, the ulcer, like initially I was talking about, your herpes simplex ulcers, they occur on your keratinized mucosa. Like you see this picture where it is. It's at the border of attached gingiva and mucogingival junction. Again, now patient will say they often get these ulcers, they stay for a week. So we are kind of on a similar time span as that of an aphthous ulcer, stay for a week and then they go, like any viral infection also. But the location is very important. Okay, now let's diagnose further female patient. Now you have to ask your patient if there is a history of fever. Again, a very important point to remember. Now, why is it important to know about fever? Because if you have a viral infection or if you have any infection, you do have fever. In our case, if the patient says that they had fever at some point before they got this ulcer in their mouth or around the same time, then definitely it is your HSV infection. It's a viral infection and it's a herpes ulcer. And your patient will say that they had fever every time I know it's an herpes ulcer. I ask my patient, did you have fever? And they say yes. Another important thing, pain. Now pain is common. If it's an ulcer, there will be some kind of pain or a tingling sensation in case of an herpes ulcer. History of cold sore, yes. You do not ask a patient if you have history of, if you are getting herpes labialis, they don't even know. If you ask them they have herpes, they don't even know that sometimes. You have to ask them if they have a history of cold sore, and they'll say yes. Well, if they've answered yes to your questions of fever and cold sore and pain or tingling sensation, definitely, I wouldn't include pain in that, but definitely the above two, then it's a herpes, and also the location dictates it's a herpes ulcer. In contrast to apthous, like we're talking about, this occur on attached gingiva, heart palate, or alveolar ridge. Now, look at this picture. If you look here, you can see this is along the distribution of your greater palatine nerve. Again, multiple tiny ulcers. Look at this location. Again, multiple tiny ulcers. This is an intraoral variant of recurrent herpes, which mimics burn due to some pizza or a dental procedure, and this takes at least 10 to 12 days to heal. Now I have two stories related to this and another one that will be talking about. So I had a patient who presented with this kind of a lesion. When the patient came to me, they were coming from another office and they started non-stop that other dentists did some work, and when they did it, they actually caused this injury in their mouth, and because of which now they're in severe pain, and they were talking about suing the other dentist because they've not been able to get an appointment, and it goes on. Now when I looked at it, it definitely did not. I asked them what was the procedure done, and the patient mentioned that they had an occlusal composite. It was a simple composite, and I was wondering, even if you would give a greater palatine or if you would get any kind of anesthetic, you cannot cause this kind of an injury. Like, what could have caused this kind of a burn kind of an injury? Well, I started talking to the patient about if they get any kind of canker sores in their mouth, or when did this exactly start, and they mentioned that it started after 2 days of the procedure. Then I asked them, have they experienced something like this before? And they said, yes, it has happened at a previous occasion with the same dentist when they did a procedure on their lower tooth, but it was not this bad and it went away in a different location, and they could not draw the correlation as to the questions I was asking, but I was trying to come up with the same with an answer as to what has happened. And when the patient said yes to my question of it happened after a dental procedure, which is obviously considered as a dental, it could be a stress, it could be a dental trauma, it can actually cause these kind of ulcers. So don't be surprised if in your patients you do see something like this, that you do a procedure, after a few days a patient comes to you at a related or an unrelated site with multiple lesions like these, which are like ulcers or looks like a pizza burn. It could be an aphthae, your aphthae ulcers. But they were basically they're not it could be aphthae ulcers, but in this case what I'm trying to show you is it's a recurrent herpes ulcer, but it does mimic like a dental procedure. So even aphthae ulcer, you can have those tiny pinpointed ones sometimes in these kind of locations. It definitely did not start here, but it was moving from your mobile mucosa to the non-mobile mucosa. But that's very rare, the story that I told you. But if you see something like this, it is most commonly it could be a recurrent herpes. Okay, and these recurrent herpes, however, takes 10 to 12 days to heal. So now let's move on to another important part about herpes labialis. Yes, these viral fluid-filled blisters or fluid-filled vesicles, anything that you would like to call them. If you see these on the corner of your lip, these are cold sore or herpes labialis. The story that I was going to mention is that I had a patient who apparently has been getting dental treatment done despite the fact that she had this. Now I know that some dentists or some professionals would not mind, but definitely I do not feel comfortable treating a patient when they're in the most active stage of fluid filled vesicle. It's not fair for the assistants or the dental staff, as you are all aware that the dentist or the professional can get something called as herpetic whitlow, or that happens on the fingers. So I asked the patient, do they know if they have herpes? And the patient said, no, it's just an allergy that happens during the cold. It comes and goes. And so far, no one has ever told them that they had herpes. Okay. So please, if you see something like that, it is fine that you would want to continue working on the patient, but just let them know that they have a situation which is called as herpes labialis. Patient definitely knows it is called as cold sore, but they did not know it's herpes. It's a viral infection. And then you can always give your patient antivirals, the most prominent like acyclovir, vidarabine. I think most commonly you'll get over the counter is acyclovir antiviral cream, and it hastens the healing of the cold sore or herpes labialis. I hope with this presentation you've understood how to diagnose an ulcer. Not only how to diagnose just an ulcer, but any lesion that you see in the mouth, what all you should be asking. You should be asking about the etiology, the history from the patient. When does it happen? How does it happen? How many days it lasts? Are there any predisposing factors like stress or nutritional deficiency? Definitely have a good clinical presentation. Try to figure out what's the size, how many times it reoccurs, what is the location. Location is very important, which help you understand if it's herpes or if it's aphthous. And then definitely based on what you see, the etiology or predisposing factor, you can give a good treatment plan to your patient.